The first one is a 53-year-old grandmother of one of our babies. She is totally asymptomatic. She had this lesion since birth and that is remaining without affecting her health in any manner. This is another 1-year-old baby who was asymptomatic at birth, and this lesion started at 2 weeks of age, a small lesion, gradually increased in size, and now for the last few months it is regressing. The change in color of the surface is become white. The first one is a capillary hemangioma in the trigeminal nerve, first division, ophthalmic division, and this one is totally different one. It's a cavernous hemangioma. The first one, capillary hemangioma, even though this lady is asymptomatic, there can be few of the associated lesions and complications within the brain, within the eyes, and occasionally some other systems also. The lesion starts from birth and it persists. About the cavernous angioma, it is a benign lesion. Usually at birth it won't be there. After a few days it just starts in a small lesion, gradually increases, and after some months to maybe by 1.5 years or 2 years it will totally disappear. There may be other lesions in the other parts. Occasionally there can be lesions internally also. So when you encounter such a clinical sign, how to proceed? First is to assess the lesion as such. The extent of the lesion itself can lead to problems mechanically, either capillary lesion or the cavernous lesions. And the second one is there can be an internal system involvement, especially for the capillary lesion in the ophthalmic division of or the maxillary division. There can be neurological problems. There can be an involvement of the eyes, and rarely there can be hematological problems, especially the thrombocytopenia, and there can be some of the cardiovascular involvement also. Few of the interesting clinical syndromes are there. One of these is the small capillary angiomas over the fingertip, lips and tongue. There can be an internal lesion within the lung. So they may present with hemoptysis because in the lung there can be a pulmonary AV fistula, and it can lead to hemoptysis. Rarely there can be shunting leading on to hypoxia. Few of the clinical signs are described. We call it as this Rendu-Osler-Weber syndrome. So always look at the fingertip, tongue and the lips for small lesions in all cases of hemoptysis. Another interesting thing is extensive AV malformations, venous, capillary, and in the limbs leading on to hypertrophy of one limb or maybe hemihypertrophy. So we call it as a Klippel-Trenaunay syndrome. The other entities, there can be an associated thrombocytopenia and coagulation disturbances. We call it as a Kasabach-Moritz syndrome. So interesting thing is you need to look for the AV malformations visible outside or internal evidence in any case of persisting thrombocytopenia. So how will you evaluate the case? First of all, what is the extent of the lesion? Sometimes even the cavernous hemangioma, even though after some time it involutes, disappear totally, initial days it can extend to the pharynx or larynx or to the neck and tongue. That can lead to swallowing problems, chewing problems, and stridor. So if it compresses on the trachea, esophagus and all, especially in the growing phase, mechanical problems it can lead to. Some of the situations of this cavernous hemangioma are liable by location to injuries and bleeding and infections. The Sturge also, the capillary angiomas, sometimes initially they are pink, later it turns to little more darkening, and there can be thickening and nodular formation and all, that can sometimes lead to local problems. So when you get a capillary hemangioma in the trigeminal V1 or V2 division, what all things will you check? You need to examine the eyes for the similar lesions and cavernous glaucoma, retinal involvement, and detailed examination of the nervous system, because there can be many of the clinical manifestations of the brain. The neurological involvement can be due to seizures, there can be hemiplegia, there can be hemiatrophy, there can be visual problems, especially visual problems can be either due to the glaucoma, or many of the situations it is the ischemia of the occipital, parieto-occipital cortex. So the involvement of the leptomeningeal capillary venous communications are responsible for the basic problems, and the underlying cortex gets atrophied and there can be dystrophic calcifications. So what you can see by radiologically, railroad calcifications can be seen, and the same side atrophy can be seen. A lot of the radiological findings are also described in the conventional x-rays and the imagings also. So you need to check for these neurological problems, visual problems, and a small percentage of cases there can be intellectual disability also. Eyes can be involvement of the conjunctiva, sclera, choroid, and retina also. So clinically you need to check for the glaucoma, you need to ask for the headache. Headache can occur due to both ways, due to intracranial problems or due to glaucoma, leading to headache. And the eyes, especially the corneal size and the haziness, need to be checked clinically. Of course, pressure evaluation is to be done by the newer methods. So thrombocytopenia is one of the interesting hematological manifestations. There can be consumption coagulopathy, DIC partial can lead to problems. One point about the cardiovascular, there can be an leaking from the systemic circulation leading to high output situation. So interesting thing is pulse can be high volume, there can be a BP change just like what you see in the case of aortic regurgitation or a PTA, and in the very severe cases it can also lead to the congestive failure. So how will you evaluate a case like this? What are the clinical signs to be elicited? Not only these three areas, the general examination there are some points, in the history there are some points, and the system examination. In the history you need to ask about the seizures. In both the situation there can be seizures, the capillary hemangioma, and occasionally there can be an internal cavernous hemangioma also. The seizures, weakness, especially repeated thrombotic episodes are possible, and you need to evaluate the headache both ways, glaucoma situation or intracranial hemangioma situation. There can be headache. The vision need to be examined in detail. There can be homonymous hemianopia or the otherwise also due to glaucoma. You need to check the fundus also for the glaucoma or AV malformations. And in the clinical examination you need to ask for the history of any of the bleeding manifestations. And in the clinical examination, skin, of course, for the extent of the hemangioma, there can be multiple hemangioma in different locations, and apart from that, of course, you need to look for purpura, because there can be thrombocytopenia leading to skin changes. And very interesting, pulse volume is to be checked, and the blood pressure for the higher or normal systolic, but the diastolic pressure is low and high pulse pressure situation, and the other painful signs also sometimes can recur. Always don't forget to check the bruit in the over the eyes and in the always check for the bruit because there can be a manifestation of internal, and you need to always check for the bruit over the liver and the other internal organs. Occasionally can be the pulmonary AV fistula also in the case of Rendo-Osler Weber. So always check for that. Eyes, as we mentioned, in detail eye examination including pressure, and